Assalamu alaikum. Good morning, everyone. Thanks to GIS for the kind invitation. Just a brief comment on the last question. In my personal opinion,
Can we have sound?
the use of here.
Yeah.
In my personal opinion, the use of two different devices related with how much deep you need to have the renal denervation. Because with the balloon device, is covering from 3 to 8. If you have a very system with a lot of branches, a lot of tortuosity, you need to choose a lot of balloons. So the cost of the procedure will be much more higher. The spiral system is a little bit more, let's say, feasible for any anatomy. Okay, maybe I will repeat some content. Let's see. Renal denervation aims to interrupt afferent and efferent sympathetic nerves in the adventitia and perivascular tissue and of renal arteries. Everyone knows about the flow chart that we are following to arrive to suggest to the patient about a possible procedure like renal denervation. We already discussed a lot about the recommendation of this kind of procedure, especially in patients with high cardiovascular risk. And the class of evidence is very clear, according with the European guidelines. The same for the American Heart Association. As soon as we are feasible to understand that there is no other secondary reason for hypertension, especially for patients with resistant hypertension, we should suggest to the patient that there is another possibility as a treatment that can be effective to treat his hypertension, which are, in my opinion, the 10 rules for safe and effective renal denervation. We need to discuss about hydration, about medical therapy, about sedation, about the vascular access that should be done by echo-guided system, non-selective angio to start to plan, selective and skewed views to decide which kind of plan you should follow, the perfect renal denervation planning, the possibility to use extra support wires, especially in tortuous anatomies, the risk of the use of contrast related with the radiation, and especially the patient information and expectation from him and the follow-up. About hydration, preventive hydration with saline 0.9 is advised to reduce the risk of contrast-induced acute kidney injury, regardless the basal renal function of the patient. This is important regardless the result of the studies. Medical therapy is very important that the usual antihypertensive therapy assumed by the patient is not discontinued during hospital stay or before the renal denervation procedure. A preload with aspirin the day before is advised, and single antiplatelet drug will be followed by 4 weeks, even if there is no scientific evidence to support this recommendation. Sedation is very important to assist the patient, especially for anesthesia. Low dose of opioids or benzodiazepine can usually provide an adequate analgesia and sedation with retrograde amnesia. That is very important. So it's firstly about the echo-guided femoral puncture. It will reduce the risk of complications, especially for this kind of procedure.
Only for TAM.
It's very important to assess the non-selective angiography to understand which is the anatomy. Sometimes we can have anomalous origin of the renal artery, we can have a single artery, we can have double artery with accessory arteries that we have to consider for the denervation that we are going to do. And then we have to proceed with the selective angiography to see the full shadow of the kidney, because sometimes, as I said just now, is present an accessory artery that should be treated as well. And then the planning of the renal denervation. We need to follow the plan that is covering IVY, that is starting from the main artery and covering even the branches, according with the size. Sometimes we need to use extra support wires, especially as you can see in the second video, where the tortuosity of the artery does not allow us to push the catheter so deep to perform the renal denervation as we want to do. And it's very important to consider that this procedure are guided by the contrast just to visualize the branches that we are going to treat. So the total contrast that we have to use during this procedure is very important, as well as for the radiation. And then it's very important to inform the patient that this treatment is going to maybe give him the chance to reduce, to control better the blood pressure, to reduce the medication burden, especially the number of the class of medication that we are using up to the decision for renal denervation. Let's go to the two cases that I want to show you. The first one is one that is very important for me because was one of the first cases I did, was a female 23 years old with dyslipidemia, with a family history of hypertension, but not at a young age. And her medical history was totally silent. The first detection of hypertension was in February 2021, hypertensive with peaks of blood pressure up to 180/130, accompanied by pulsating headaches, epistaxis, and skin rashes. She was having asthenia, palpitation, exertional dyspnea, with limitation of functional capacity. And she started to have onset of epileptic seizures that were treated with lamotrigine. After 6 hospitalizations for diagnostic assessment and the evidence of difficult to control hypertensive peaks despite therapy, we were following actually because she was coming from another center. We were following all the tests that she did according with the age, just to exclude any potential secondary reason for hypertension. Nothing was found, and according with the flow of the medication, the amount of medication that this young lady was having, she was recorded with the blood pressure during ABPM monitoring with the constant systolic diastolic hypertension with average of BP of 145/90/110, not deeper pattern, with peaks up to 170 and 115 millimeters of mercury. So our center was contacted. At that time I was in Italy. There was a multidisciplinary team discussion. After excluding secondary form and according with the diagnosis with the resistant hypertension and the evidence of disabling symptoms with psychological impact, we decided to go for renal denervation. So after the first non-selective angiography, we performed the selective angiography. The procedure was done by right femoral access 6 French. The duration of the procedure was 67 minutes. We performed 14 ablations with the spiral catheter on the right and 15 on the left. And total contrast use was 65 ml. And the patient was mobilized in the following morning. And the therapy at discharge was unchanged. This is just an example of the map that we were just drawing just to document the ablation that we were doing. At the follow-up, there was evidence of reduction of her blood pressure, especially in daytime and mostly in the nighttime. And in this table, we are just showing the mean day and night systolic blood pressure and the diastolic from the time of the first month up to the second year of follow-up. And even according with the therapy, after renal denervation, she was having reduction of drugs burden and the therapy burden. The second case is for a male 74 years old, dyslipidemic, with family history of hypertension, medical history silent up to the 2018, hypertensive peak with blood pressure up to 220 and 120 millimeters of mercury, accompanied by palpitation and lower limb edema with exertional dyspnea, and the limitation, evidence of limitation of functional capacity. So during the last 6 years, he had many visits to emergency for very high value of blood pressure. We performed the full diagnostic evaluation, excluding any other secondary reason, and the evidence of difficult to control hypertensive peak despite therapy. We considered the medication that we were adding every time it was coming to the ED, and the BPM was again showing the constant systolic diastolic hypertension with average of 165/90 and 110, no deeper pattern even for this patient, peaks up to 185/115. Even here, after a team discussion and after excluding any secondary form, we decide to suggest to the patient to undergo for renal denervation. The renal denervation, I will be fast, was performed following the same flow chart that we are following, right femoral access. In this case, we performed 25 ablation on the right, 36 on the left. The duration was 55 minutes, total contrast 75 ml, and even this patient was mobilized the day after, and with the therapy at discharge that was fully unchanged. Even for this patient, the follow-up is a little bit shorter, but there is a clear reduction of the blood pressure for all the values that we are considering, from the main, the night, and the day, systolic and diastolic. So in my conclusion, renal denervation is technically a simple procedure. The most important aspect of a successful RDN program is the organization and multidisciplinary hypertension team. Management of the pain is the key. Minimize vascular complication and volume of contrast is very important to reduce the complication. Plan of denervation strategy and good quality angiogram is another key. And share the expectation and clinical behavior with the patient and the referral physician before and after the renal procedure. Thank you very much.